to In the ED Now, a podcast that makes you a better emergency department physical therapist. My name is Dr. Rebekah Griffith, the EDDPT. I'm so happy to be with you today. One of the things that I wanted to talk about is this concept of, before you ask for value, demonstrating value. So I have a lot of physical therapists that reach out to me in the emergency department, and they're having a hard time feeling valued. They're feeling like they can't get into the ED, that nobody knows what they do, and it becomes this whole issue. But when we talk about expecting value, we need to provide and demonstrate value first. So I wanted to talk about the emergency department PT benefits. So what are the benefits of having physical therapy in the emergency department? So there's so much research on this topic. A lot of people think that there isn't, but there really are over 100 references that support emergency department PT practice. And if you're looking for those references, you can find them on our website, the EDDPT.com. Under resources, you can download a huge reference list. It's not exhaustive, but there's a lot of great information there to help you get started. But the common themes are supported by both national and international research. So some of those themes include increased patient satisfaction, decreasing the cost of unnecessary care, increasing the treatment and service options that are available to you in the emergency department, improving patient function and outcomes, and improving productivity and operations in the emergency department. So all of those things have tremendous value. So we need to leverage those things in order for us to be able to demonstrate our value. And once you've really demonstrated all of those benefits and all of those values of having a physical therapist in the emergency department, that value is going to be returned to you. Your practice will be supported, you'll be getting consults, you'll be able to get the staff and resources that you need. So let's talk about each of these in a little bit more depth. So patient satisfaction is a huge one. One of the best ways to discuss that specifically is when you think about going to the emergency room. People have different expectations for care, right? So most people want a fast diagnosis, a clear cure. They want to spend time with the provider. They want to be heard. Unfortunately, the emergency department doesn't really provide any of that, right? It provides maybe 5 minutes of triage, a quick consult with a provider, a long time waiting for maybe an unnecessary test, maybe a necessary test. And then usually at the end, just to be told this is not an emergent condition. Please follow up with your primary care physician. So that can be extremely frustrating for patients, and it's also extremely frustrating for providers because the goals of the emergency department and the goals of the patient are often at odds. So the other thing we hear a lot is patients come into the emergency department and they really don't understand the goal of the emergency department. So they might be coming in for something that's not necessarily emergent, but it is impactful and emergent to them, and they may have nowhere else to go. So considering that, when we think about how do physical therapists in the emergency department increase patient satisfaction, there's lots of different ways. So I have a case example for you. I had a patient who was in a rear-ending motor vehicle collision, young man. He came in on a cervical collar. The physicians had already triaged him, removed the cervical collar appropriately, didn't order any imaging. It really wasn't warranted or indicated, and said, hey, you can discharge and follow up with your regular doctor. Everything looks okay. And family was just livid. It felt like this was an unsafe discharge. He didn't really get a real evaluation. And so we were asked to consult as a second opinion, which I think it would have been probably even more appropriate if we had seen that patient initially, because we really would be the right providers for this type of diagnosis. So we're able to really confirm that discharging the cervical collar was appropriate. We also agreed there wasn't any need for unnecessary imaging. We did a really thorough upper quarter screen, functional screen, talked to the patient about their goals, what their limitations might be, the symptoms that they were having, gave them some comprehensive education and a resource guide, as well as access to follow-up care. So spending that time doing that thorough evaluation really made the family and the patient feel more at ease. It also prepared the patient to know what to expect and how to follow up on their own. So I think that was a really good example of one way we can improve patient satisfaction. Also, if you come into the emergency department and we can take away your pain, huge for patient satisfaction. If you come in after a fall and it's not safe for you to go home and family's been really worried about you and you've been worried about yourself and we can get you to rehab placement, which might be appropriate, that also increases patient satisfaction. If you come in feeling incapacitated by dizziness and we can do maneuvers and take that away, of course you're going to feel satisfied. Additionally, PTs have been shown to increase provider satisfaction as well. So I know that wasn't on the initial list, but all of the research bears out that physical therapists are very highly valued by their peers. If we are the right provider at the right time, then we allow our emergency providers to focus on their patients that have critical medical needs. So decreasing the cost of unnecessary care is a big one. And when you're talking about adding value, retaining value, and decreasing costs in the emergency department is huge. The ED is a money pit. So if we can decrease unnecessary imaging, if we can decrease unnecessary hospital admissions, if we can reduce the number of specialty consults that are required because you saw maybe a physical therapist instead of an orthopedist appropriately, then that also decreases the cost of unnecessary care. Physical therapists have also been shown to really improve throughput time, which also decreases the cost of care because patients aren't being held in the emergency department longer than they need to be. Additionally, we can start seeing patients who are admitted to the hospital but don't have a bed upstairs right away. And if we do that, that can decrease the cost of unnecessary care by preventing delirium, urinary tract infections, pressure ulcers, other mobility deficits, deconditioning. We can get those patients up and moving, make recommendations for them, and get their discharge plan rolling right away, which will help save the hospital as well as the patient money and time in the long run. When we talk about treatment options and services available in the emergency department, there aren't that many options, right? Like our physician partners don't have a lot of interventions necessarily at their fingertips. They can send patients for testing. They can provide medications. They can recommend different types of follow-up. They can give some patient education, but they don't have the same arsenal of therapeutic interventions that we might have. So we have lots to offer. We have manual therapy. We have functional training. We have exercise, we have dry needling, we have multiple other modalities. We have a huge background in education related to non-pharmacologic pain coping tips. We also have durable medical equipment, and we can make referrals for home care and other services that will help support our patients. So by allowing our patients to access additional treatment and service options in the emergency department, that helps decrease those hospital admissions. It helps keep patients from bouncing back, and it gets patients started on an appropriate plan of care immediately rather than waiting 3 to 4 weeks to get into a physical therapist. We also know, if we look at the literature from Julie Fritz about low back pain, if we know that within 90 days, people who see a physical therapist for their low back pain are likely to have approximately $3,000 less in costs associated to the healthcare system with their low back pain, as well as improved outcomes. What do we think the benefits of somebody seeing an emergency department physical therapist immediately would be on those costs and long-run back pain, especially if those patients are coming to the emergency department anyway? Obviously, if we could send these patients to the outpatient clinic and not to the emergency department initially, I think that would be the better bang for the buck, obviously. But sometimes patients come to the ED because they can't function. And while we have the biggest cover charge for physical therapy ever in the emergency department, we can get people treated and started right away. When we talk about improving patient function and outcomes, this is one of my favorite things. And the reason for that is this. If patients come in and they're having trouble functioning, that can turn into a problem that's very large very quickly. So one example that I want to give to you is, say your older adult patient who has congestive heart failure and they are taking LASIK medications, but they have some instability and some fear around mobility in their home. So they're afraid to get up and go to the bathroom because they're afraid they've fallen in the bathroom, or they've been falling at home, or they don't have the right equipment that they need. So that patient does what? They stop taking their LASIKs, they stop drinking, they stop eating because they don't want to have to get up and go to the bathroom. So now you have a patient who's volume overloaded, isn't drinking water, so might be dehydrated. You have somebody who is not getting the nutrition that they need, and maybe they're also hypoglycemic. As that volume overload takes over, the patient potentially becomes more hypoxic. They become a little bit more confused. And what happens? They fall and they come to the emergency department. So by improving the patient's function, perhaps by giving them balance training, the appropriate assistive device, setting up home care, and giving them education about how to safely manage their mobility, hopefully we can get that patient's medical care back on track, partnering with our medical team to get them diuresed or whatever it is that they need. And then we can educate them, improve their mobility, and hopefully stop that cycle from continuing. Also, if this is the first time you've fallen and you've just had a little bump, but we can prevent you from falling again and having a subdural, the cost benefit there is huge. So I love improving patient function. One of the best things about practicing in the emergency department is the delta of change that you can see right away. And what I mean by that is if you have a patient who's coming in with low back pain, screaming on the gurney, they're prone on the gurney, you can't get them up, you can't get them moving, and then the physical therapist sees that patient, helps calm them down, helps them find a position of comfort, uses their reassurance, their pain science education, their manual therapy skills, and their functional modifications. And that patient's able to get up and walk out of the emergency department unafraid to move and in way less pain. There's nothing more rewarding than that. It's really rare to see that huge of a change in other settings. So a lot of administrators, when we talk about value, if you want to get value, you have to give value. One way that physical therapists give that value is by improving productivity and operations within the emergency department. When we look at how an emergency department runs, there are a lot of really crucial metrics, okay? So one of those metrics is bounce back. That's the number of patients that are discharged from the emergency department. They go home, they go on to another facility, whatever it might be. And then because potentially their concerns weren't resolved, they couldn't get follow-up care, whatever the case might be, they bounce back to the emergency department. That's recidivism, when patients come back within a certain amount of time, often for the same concern, sometimes for lesser concerns. That's a huge metric that emergency departments are measured on. So we have found anecdotally that patients who come to the emergency department and are seen by a physical therapist are like 50% less likely to come back for the same complaint. And the example with that would be like if you came for low back pain, you're 50% less likely to come back for that same low back pain. Now, some patients are going to come back no matter what. They don't have anywhere else to go. They might have poor health literacy. They might not have been able to access the follow-up that was requested or recommended. All of those things are possible. But if we can get the patient the right discharge plan, if we can take care of their primary complaint, if we can make sure they have all the tools they need to succeed in that first visit, then we're going to decrease that bounce back. Another big metric is throughput time, and that's the time it takes basically to get a patient in and out of the emergency department. Waiting is one of the biggest issues in the emergency department, and we know that the ED is not first come, first serve. So our patients who really need physical therapy, they're not the ones getting chest compressions, hopefully. So we have patients waiting in the emergency department for musculoskeletal issues. We have them waiting for testing. We have them waiting to see consultants. We have them waiting because they have vertigo. We have them waiting because they might need placement. So there are so many ways we can help streamline that waiting process. First, if we get rid of the unnecessary imaging, you never have to wait for it to begin with. Second, if we're the provider that can see that patient while the medical providers are seeing another patient, then we can get that patient seen and discharged. If a physical therapist has their own room in the ED, and that there are 4 patients in the waiting room for musculoskeletal pain, we can easily pull those patients out of the waiting room to that space, address those complaints, make any additional connections for medical issues, and get that patient on their way. That improves throughput time and productivity. That allows our physicians, our physician assistants, our nurse practitioner partners to focus on those complex medical issues. That will help streamline productivity, throughput time, and operations. If you have bedlock in your emergency department because you can't discharge patients because they don't have a safe discharge plan, that decreases the productivity and operations within the entire hospital. So having physical therapists at the gateway of your hospital in the emergency department, or as my friend Sarah likes to say, the front porch of the hospital, if we can move things efficiently from a discharge planning perspective right there, rather than waiting for that patient to go upstairs, productivity and operations are going to increase substantially. So those are some of the few ways that we really help with value right up front. But one of the other things I want you to consider is, what is your goal in the emergency department? The goal is to get those patients out of the emergency department. And that sounds a little harsh, but really that's the goal. Obviously, we want them to be better than they came in. So if you came in screaming with low back pain, I want you to walk out of there pain-free. Doesn't always happen, but if we can do, that's the goal. But the goal is for you to get to that next step as nicely as possible. So every time we encounter a patient in the emergency department, we have to be thinking, where do you need to go next? And how can I get you there? Because you don't have to go home, but you can't stay here, right? So we need to get you onto that next step. And that really is where our discharge planning expertise shines. It's where our patient management skills shine, because we can get into that patient's room, receive a patient-centered history, understand the functional and environmental demands of their life, and then figure out how to match those gaps with needs and fill those needs to get that patient out quickly, effectively, and on to the next step. If we can do that, then we're definitely adding value in the emergency department. So I have a quote here from a physician assistant that I want to add. Any shift I work where a patient requires co-management with physical therapy lends itself towards better outcomes. PTs possess a skill set that's not taught to PAs. Together, we provide better, more comprehensive care. That team-based approach to really get the patient the right provider at the right time adds tremendous value. When we talk about the actual costs, the value of physical therapy in the emergency department does support a primary contact model. So there is research by Bird et al. From 2016 that shows a primary contact physiotherapist model in hospital emergency departments reduces waiting times, reduces treatment times for patients in this study, specifically with musculoskeletal presentations. And the wait time to see a primary contact physiotherapist was 31 minutes less than seeing another provider. And the treatment time overall, or the management time we'll call it, was only 108 minutes versus 148 minutes by other providers. So that puts value back into the emergency department. Additionally, less money is lost from emergency departments when you have a physical therapist involved. Again, because we've decreased all that unnecessary work. Reimbursement that's provided for things like MRIs often doesn't match the actual cost, and that costs the emergency department money. And physical therapists are not an expensive professional to add to the mix, right? We practice independently, we don't need a tremendous amount of equipment, and we help prevent chronic progression to reduce cost loss. So I think when we think really, how can we show our value? The other issue is we have to get past those barriers of people who don't know what we do. And that comes from educating other providers. So these quotes are from an article by Michael Lebeck. I myself was very skeptical when I heard that physical therapists were coming to the department. I didn't really have a good understanding of how it might aid my practice, and it has greatly aided my practice. I think it's an unrecognized need. I certainly never would have sought out physical therapy services, and I'm the medical director, but now I can't imagine working in a department without them. So we'll have another episode on barriers to like physician barriers for perception of physical therapists in the emergency department. But just know that we can get past those. And this quote by Dr. Howard Kim really sums it up nicely. As to our value in the emergency department, physical therapists are an integral part of the emergency care team due to the expert knowledge of their musculoskeletal pathophysiology and unique therapeutic skill set. Emergency physician education and training tends to emphasize the identification and treatment of life-threatening conditions, and rightly so. But this focus in the setting of multiple competing demands in a busy emergency department often results in a brief targeted exam and limited guidance for patients with musculoskeletal issues. ED physical therapists are able to provide a more complete assessment with better precision and expertise, as well as a more nuanced patient discussion regarding the diagnosis, etiology, expected symptom trajectory, and plan for functional recovery after an ED discharge. How beautiful is that? That just sums up exactly what we do. So the next time somebody asks you, what does a physical therapist do in the emergency department? Or really anywhere, I want you to say, we provide a complete assessment with precision and expertise. We provide a nuanced patient discussion regarding their diagnosis, etiology, symptom trajectory, and a plan for their functional recovery. Chef's kiss. So, in order to get value, we have to give value. And these are just some of the bare like most basic ways that physical therapists do that in the emergency department. So if you've been trying to figure out how to demonstrate your value in the ED, this is the research-backed information for you. If you want to learn more on how to streamline and optimize your practice in the emergency department, we do have options for you. We have a course coming up that will be provided virtually. You can attend from anywhere in November of this year. We also do offer consulting services to come into your emergency department, help you add that value, help you demonstrate that value, and how to streamline your practice to make it sustainable. In addition to that, if you're like, gosh, I hear you saying that we should do all these management things with musculoskeletal issues and dizziness issues, we've got you there too. We have our upcoming courses on musculoskeletal and dizziness management in the emergency department in August and in September of this year. So if you're looking to level up, that's the way. The last thing I'd ask of you, if you listen to this podcast today and you enjoyed it or found some value from it, like and share this podcast. Additionally, consider applying for our Top of Scope Summit. We're on the search for presenters. That will be held in November of this year. So go to our website for more details on our courses and on how to get involved. You've been in the ED now, and you're officially discharged. Thanks for listening. Thank you for listening. In the ED Now is a podcast hosted and produced by Rebekah Griffith, the EDDPT, as part of Rebekah Griffith Physical Therapy, LLC. Our podcast makes you an excellent emergency department physical therapist. This podcast is intended for educational use only and is not intended as clinical or medical advice. While we make every effort for accuracy, factual errors may be present. Since you've been in the ED, I'm prepared to give you your discharge instructions. Please subscribe, share, and find more at the EDDPT.com. You're officially discharged.